So good afternoon. Thanks for the kind introduction. It's my first time on this stage, so it's a great honor and pleasure to be here. Thanks for coming. Today, I have the pleasure to host a presentation on percutaneous cryoablation, which is an emergent treatment with incredible potential, whose potential has also been acknowledged and recognized in the latest edition of the consensus paper from the working group. So in this past 2 days, we have heard a lot of testimonials from people who in various ways take care of patients affected by DT. And today I am representing interventional oncology, which is now recognized as the fourth and probably the fastest expanding pillar of oncology care. By now, we are all familiar with the diagnostic and therapeutic workflow of patients with a suspicious diagnosis of DT. That really starts with a confirmation of such diagnosis by means of an experienced pathologist with dedicated experience on soft tissue neoplasms working at a referral center. Then, multidisciplinary discussion is mandatory in order to decide and opt for the optimal strategy for such patients. And this decision mainly makes the distinction between active surveillance or active intervention, which is mainly regarded in cases, as we have already seen, in which we have persistent progression upon active surveillance, which is defined as persistent progression, at least 2 progression in consecutive follow-up, or threaten to life, function, or quality of life. Now, local ablative therapies have really entered the scene and are now considered among the primary treatment options for patients affected by extra-abdominal diseases. The situation is different, as we already said, for mesenteric tumors, retroperitoneal, and pelvic tumors, as in these cases, cryoablation is typically not offered among the primary treatment options. An intermediate situation can be found for selected head and neck desmoid tumors requiring treatment, for which cryoablation is typically offered after failure of medical therapy. But how does this fascinating technique works? It leverages a physical phenomenon, which is called the Joule-Thomson effect, which states that whenever a gas expands without doing any work, there is a substantial change in its temperature. There are some gases that display a positive effect, and this means that they increase rapidly their temperature upon expansion, whereas some other gases display a negative effect, which means that they tend to cool down dramatically when they expand. So the whole system of the probes, which are inserted in the target volume upon imaging guidance, is the fact that we pump a gas, specifically argon, within a very narrow opening, and then let it expand at the tip of the cryoprobe. This rapid expansion leads to the rapid cool down of the gas, which in turn is rapidly transmitted to the metallic covering of the probe, resulting in rapid freezing of surrounding tissues. Then the same mechanism is leveraged in the thawing cycle, the thawing part of a cycle, in which we use a gas with a positive Joule-Thomson effect, such as helium, which, when is left free to expand, will augment its temperature, realizing a thawing cycle. But how does this translate in terms of biology and target tissues? Well, during the cooling phase of a cycle, there is the creation of highs in the extracellular space. This, in turn, reduces the tonicity and osmolarity of the extracellular fluid, which means that it becomes less concentrated. This attracts water from the inside of the cells, and this in turn leads to cell shrinking and malfunctioning of a lot of structures that are normally located within the cells, for example, enzymes, proteins, and also damages the integrity of the membrane. Also because the cooling creates some microspheres of ice, which directly interfere and damage a lot of structures within the cell. During the thawing part of a cycle, the opposite phenomenon takes place. And so we have a reverse inflow of water, of free water within the cells, which tend to swell and then burst because of extensive damage to their membranes. How it is performed? We have specified that the probes are placed under imaging guidance, most often the case with CT or other MRI, sometimes with the utilization of ultrasonography in order to better define soft tissue anatomy. It is performed under general anesthesia, so no pain is felt during the procedure, of course. Several cryoprobes are typically positioned depending on the extension and location of desmoid tumor, and we tend to keep a distance in order to let the physical phenomenon to happen without significant overlap. And we perform several cycles because, as previously mentioned, both the freezing and the thawing part of this cycle are helpful in order to destroy the target tissue. And very important, whenever we are practicing this technique, we have to take into account some safety margins. This means that we should go beyond the target volume of approximately 5 to 10 millimeters. And this allows to be much more safe regarding the quality and the outcomes of the procedure, as we already know that oftentimes persistent or relapse of disease tend to occur along the margins of the ablative techniques. And this is something that we have observed not only for desmoid tumors, but even with similar ablative techniques elsewhere in the body. Of course, this technique, which is very complex, comes with some criticalities and technical difficulties that we have to be able to overcome. And most of these technicalities come from the fact that a lot of tissues are very sensitive to this heat shock damage. The first of these tissues is skin. For example, you can see in this case how close the lesion is to the surface of the skin. Or for example, we might be very close to abdominal viscera, such as the bowel or large vessels. Or again, we might be very close to neurovascular bundles. Vessels and nerves tend to be very sensitive towards heat shock damage, and so we have to be very careful. What are the strategies that we might leverage in order to overcome such limitations? To begin with, we make use of warm gloves, which are applied to the skin throughout the whole duration of the procedure. This avoids abrupt changes in skin temperature. Or, for example, we can use hydrodissection, which literally means the separation of a different place of subcutaneous tissues by using water. This simply creates a distance between the ice ball, which is the region we are cooling, and sensitive structures. And another very important features of this technique is that we can monitor the ice ball, so the area that we are freezing, in real time under CT guidance. So this means that not only we can be sure about to which extent we are ablating the lesion, but also we can keep our margins very safe, because if we see that we are getting too close to sensitive structures, we can simply pull back or readjust our position. Other techniques that we can employ are, for example, pneumoperitoneum, which literally means the injection of air within the abdominal cavity, so that we can, for example, in this case, create a distance between the ablation zone and the ice ball and abdominal viscera and bowel, which are again very sensitive to abrupt changes in temperature. Here we can see a final case of an abdominal DT, of a DT of the head and neck region, where we have employed all these strategies together in order to target a very sensitive region of the body. But what is the result that we are expecting when using cryoablation or other similar local ablative techniques? It is not always the case that we can immediately see a dramatic shrinking in size of a lesion, but there are other cues that we might leverage to interpret response to such therapies. Here you can see a particular acquisition that we use in MRI, which is called the T2 sequence, which let us understand how solid or liquid a tissue is. And the fact that we see a very black, we call it hypointense rim, means that we still have some sort of a fibrotic capsule, but the inside of the tumor is very bright. And this means that most of the tumor is liquefied. So at this stage, we do not see any solid tissue, and this is indicative of a very good procedure that has yielded good results and has destroyed the target volume. This raises some methodological questions over how we should evaluate responses after ablative local treatments. As you may have heard today, we tend to use RESIST criteria, which are dimensional criteria to assess the efficacy of treatments and for monitoring of patients in clinical trials. Modifications of such criteria have been used, for example, in hepatocellular carcinoma, so liver cancer, in order to evaluate only viable tissue, for example, the tissue that is vascularized and which is indicative of active tissue. We have decided in our preliminary analysis to use a modified version of this criteria to only look at the viable part of the tumor. How do we do this? Well, we can consider viable each part of a tumor which is vascularized, so which takes up contrast agent, or using information that are derived from other complex sequences such as diffusion imaging or T2 sequences, as I've shown you before. A very bright signal indicates that the tumor is liquefied. Now, all of this is already been in part established and explored in the Cryo-Desmo 1, which has already been mentioned, which was a prospective open phase 2 trial assessing the safety efficacy of cryoablation. And one point that I'd like to highlight is that cryoablation is a safe procedure. This is a table that shows a vision on adverse events, and you can see that the vast majority are grade 2 or below, which actually means that it's very mild adverse effects with no serious consequences. Now, I'm going to briefly talk about our experience in Milan about cryoablation. This is the series of 27 treatments that we have performed in the recent past in Milan, treating desmoid tumors that were either after active surveillance or other lines of treatment in several districts of the body. These are the preliminary results immediately after the procedure, approximately 30 to 40 days after the procedure. Now again, how to interpret this graph? In yellow, you see stability of disease, which means that the viable tissue, so viable tumor, doesn't show striking changes. So we are between the plus 20 and minus 30 that we were talking before. In green, in the two shades of green, you see light green partial responses. So this means that vital tumor has shrunk at least 30%. And in darker green, you can see all those cases in which there is no evidence of viable tissue after cryoablation. So it's striking how even this is a very early time point that we have a lot of complete responses. This was confirmed at a later time point, where on the one hand, we saw that there was still no progression up to 10 months after treatment, and again, a significant proportion of responses. And I'd like you to focus your attention on the fact that complete responses are enduring. So even at this later time point, there are still complete responses with no evidence of disease. And even a later time point, so ranging between 11 to 16 months, the situation is maintained. And I'd like to show you that, again, we have enduring responses. All those complete responses that we were able to detect right after treatment are sustained at a 16 months time point. Now, just for comparison, you may remember that first I said that we are evaluating viable tissue because we are persuaded that when dealing with local ablative therapies, we have to only consider viable tissue after treatment. What if we try to apply conventional RECIST criteria, which do not take into account this nuance and are not really tailored for local ablative therapies? We see that actually we would miss a significant proportion of responses, because if we only look at the maximum diameter, we can see that there is not a significant proportion of, there's a significant proportion of lesion that maybe shrink in size in not such a significant way, but they do not contain or contain very limited viable tissue. So what is the key message here? First, that cryoablation, based on our experience, is safe and effective for the treatment of extra-abdominal DT, which require treatment, and that we also have a more methodological concern, which is the fact that we have to rethink the way we assess responses, because criteria that we are accustomed to using in other contexts may not be suitable for local ablative therapy, at least in this specific scenario. So this was the end of my presentation. I thank you all for your attention. And of course, I thank all the members of my team who have constantly supported me. Thank you. If there are any questions, I would be happy to answer. Yes, please.
Thank you for the presentation. So just to clarify, for the mesentery, this is still not targeted enough or accurate enough for it to be safe, or do you do anything in mesentery at this stage?
For mesenteric, it is typically not offered mainly due to peculiar anatomical constraints and close proximity to sensitive structures. So it's not offered as.
Do you think it'll get more accurate in time, or is that nothing
I
in the
don't think
foreseeable
it's a matter
future?
of accuracy, is the fact that in other districts we are able to distantiate structures, whereas this cannot be done in the mesentery because it is tethered to the bowel. So I don't think that it's a matter of precision, it's a matter of anatomy.
Okay, thank you.
Yes, I'm wondering, so what would this look like for someone with FAP who has like multiple active desmoid tumors?
Well, again, if localization are in the mesentery, I would not, I mean, this is not included as the first line treatment. So regardless of uni or multifocality, if lesions are located in the mesentery, percutaneous cryoablation is definitely not the first option to consider because of like anatomy.
Thank you.
No worries.
Thank you. I have two questions. The first one is which one you will say is the best location to obtain complete response, and what would be the location that is most difficult to obtain anatomically complete response?
Well, I would say based on our experience that abdominal wall lesions are typically showing good responses, and they do not display some of the difficulties and anatomical constraints that, for example, head and neck tumors display. So based on like the risk of damaging susceptible structures, I would say that abdominal wall gives us more safety margins, whereas in the head and neck region, we have to be much more careful about vessels and nerve bundles. So yeah.
I would have expected it to be the extremities, the one.
Sorry?
I would have expected to be the extremities, maybe.
Yeah,
easier.
also the extremities. Yeah, of course. Yeah. Extremities and abdominal wall easier, head and neck more tricky.
Yeah. Well, the second question is, have you look into the threshold with how much residual disease is the one who's going to trigger the earliest or more massive early recurrence? I mean, where's the threshold there that the tumor is going to come back earlier?
Okay, we haven't made a quantitative evaluation, but that's definitely coming because not only from like the minimal burden disease that is predictive of the timing of relapse, but also like an assessment of signal of MRI signal per se. So because this, of course, although this is a modified version of RESIST, still we are looking at the longest diameter, but we know that there is a lot of data embedded in MRI that we're not using. So quantitative models are on the way for sure.
Thank you.
Thank you.
In the instance of not getting the whole tumor, would the remainder that maybe didn't fully die off be, for lack of a better word, kind of angry and a little bit more aggressive?
Well, when we see recurrence or persistence of disease, this tends to be in a location which maybe has not been fully treated for whatever reason, maybe because it was too close to a structure that could not benefit for cryoablation. So yeah, definitely when there is an area that has not been fully treated or with not enough safety margins, that where we expect for the tumors to grow. Not because that part of the tumor is intrinsically different, but simply because we have not provided enough power to that region. So we have spared it basically. And for example, to this end, I can show you maybe later that we have had a case where we had a very large lesion, which was spanning from the thoracic towards the abdominal wall. There was one part of the lesion that we could not treat with percutaneous cryoablation because it was very close to the emergence of a brachial plexus, so where the vessels and big nerves of the superior extremity are. And we had to resort to chemoelectroporation, which is another technique. And where we saw persistence of the disease was exactly the place where we could not use cryoablation because it was too close to structure. So we didn't reach that with enough power. So that's where the tumor began to grow again. I wouldn't talk about an increase in aggressiveness. The fact is simply that if you do not deliver enough energy to destroy the tissue, it's gonna grow back. So if you treat the part of a tumor that receives enough energy is destroyed, but if you under treat one part, that part is likely to be the one that will relapse.
Would this be advised against piggybacking off of that, a tumor that's growing on or next to, for example, the axillary nerve due to risk of damage to the nerve?
Yes, one of the main contraindications that in our experience we have is that if the lesion is very, very close to nerves or vessels, maybe cryotherapy should not be advisable as a first option, definitely.
Thank you.
Stemming off of that, do you have any recommendations for somebody who has already experienced nerve damage due to the gas in this treatment?
Well, the potential damage to nerves does not really come from gas, but from heat shock damage. So if you really switch temperature too fast and too dramatically in the close proximity of a nerve, it gets damaged because of cell membrane damage, not because of gas, but because the temperature switches too fast. So like the main advice is to not perform cryoablation when you are so close to the nerves that you cannot use any of the strategies that we have displayed in order to spare them. Yeah.
Thank you, Andrea. Just a comment for the question about cryoablation in FIP patients in multifocal. So cryoablation can be feasible also in FIP patient, but not in the intra-abdominal location, but we perform also cryoablation for extra-abdominal location. So it's a local treatment also for FIP patients.
Yeah, of course. I'm sorry if that was not clear enough.
Sorry, Andrea, just to add.
There's been a lot of innovation, it seems like, in terms of systemic therapy. What advances in the pipeline do you see for cryoablation that would improve efficacy or something else?
So what could stem improvements for cryoablation specifically? Well, I think that as of now, it is already a very safe procedure. And I think that maybe innovation may come from radiology, from the quality of the image that we can produce. So we can be better and better at delineating the margins of the ice ball and be always more and more precise over the area of treatment. So that probably will be the fastest developing area. Better images to have better control in real time.